reintroduce yourself because some people arrived after her introduction.
Right. Hi, everyone. I'm Michelle. I am a second-year MPH student, hopefully graduating in May. And this actually, the DOLPH project is going to be incorporated into my capstone project. So for us, it's a 9-credit-hour course. And I'm really going to be looking at what you guys do in terms of inter-rater reliability using some of the instruments that you'll be using. So this project has really become engrossed with my MPH experience, and so I'm really hoping we get some good results, and I'm looking forward to the project moving forward. So now that you guys have heard a little bit more about prevention and investigation, I just wanted to spend a few minutes and talk to you guys about a case study in foodborne illness, which occurred at Corky and Lenny's, which is a local Northeast Ohio deli that's been serving its community for over 50 years. So it's really well established. But back in 2006, a couple called Cuyahoga County Board of Health and reported that they had gastrointestinal illness after having a meal. Ironically, the same day, the Ohio Department of Health also reported to CCDH that there was an incident reported to them as well. So in order to facilitate active case findings, they sent alerts to the local health departments in Northeast Ohio, and the week later it was sent to all the local health departments in Ohio to keep a lookout for this. And they were able to determine other complaints as part of this, as well as after our local news aired a report on the outbreak, or the potential outbreak. So Cuyahoga County responded by an epidemiological and environmental investigation into the matter, where they did a detailed review of the menu and food preparation process, as well as food samples that were collected and stool samples from the ill patrons. So after this, they ended up finding 48 confirmed cases, which is defined as an individual going to Corky and Lenny's between those days who subsequently became ill with diarrhea and/or fever and tested positive for Salmonella. There were 64 probable cases, which were same thing. They patronized Corky and Lenny's, but they either did not submit a specimen or they tested negative for Salmonella. There was a total of 113 cases, so it was pretty widespread. Apoorva had brought this up earlier, but the burden of illness pyramid, it'll show here that the case definition is set at the local health department level. And so at this case, it may exclude cases that we can't document. So even though you start at the bottom level of the population, then you get exposed, become ill, it just shows how the LHD really impacts all the bottom of the pyramid. And just, specimens weren't always obtained, and they weren't always positive, so it just shows how that level really impacts the rest. And so just Salmonella is a foodborne illness. To give you guys a little bit of background, it's transmitted by consuming contaminated food or water, or by direct, indirect contact with fecal matters from infected people or animals. Salmonellosis is a bacterial disease commonly manifested by an acute enterocolitis with sudden onset of the following symptoms. And even though the incubation period ranges from 6 to 72 hours, symptoms generally occur between the middle of that. So after investigation, they found that there was cross-contamination of the oil used in the matzo ball preparation. So the workers would put oil on their hands to keep the matzo balls from sticking. But they were the raw matzo balls, so they had the possibility to become contaminated with shell eggs. The oil that the workers would dip their hands into would then be poured onto cooked chopped liver to keep it moist, and then that was served. So kind of problematic, and the oil that CCBH collected and sent to ODH for testing was positive for Salmonella and fecal coliforms. Not really the best thing to be happening, and so the findings revealed actually a multitude of issues, not just with the contamination, but malfunctioning equipment. The high temperature dish machine was not reaching an adequate temperature to properly sanitize dishes. Alternative methods of proper cooling weren't hitting the exact temperatures needed to keep things from being sanitary, and as well as raw foods weren't stored properly, they found, and several employees were observed eating and drinking while preparing food. So bunch of different problems with this, and this is at a restaurant or a deli that's been run for over 55 years. So these things happen. So the key points from this is that finding the true source was necessary to decrease morbidity, because even if they saw that people were getting sick from the chopped liver, it was more that, you know, if they removed that from the equation, the oil would still be permeating and making people sick. So it's very important to do a thorough analysis. And they checked the corned beef, they checked a bunch of different food sources, and through the epidemiological investigation found out that it was the oil in fact, and the food preparation method that was causing people to get sick. So this was a very brief overview of the case study, and I'm going to turn things over to Dr. Frank now, also thanking the Cuyahoga County Board of Health for their help with this, but I will turn things over now for a continued look into the investigation and management. So.
Can I ask you a question?
Please.
So some of these issues related to malfunctioning equipment and practices that may have been followed for a while, but just during a regular food inspection, would that have been picked up?
That's a great question, and the answer is sometimes yes, sometimes no. That's why we don't use just routine food inspections, but also food inspections that are in response to complaints. You can see in this case, with the number of cases there were in the community, at least 113, and there were probably many more than that that weren't reported. The whole process had gone on for some time before it got reported to the Cuyahoga County Board of Health and the Ohio Department of Health. And part of the reason for that, if you were paying attention when Michelle mentioned the latency period between time of infection and time of symptoms, if you're 36 or 72 hours out before you get symptoms, you tend not to be blaming it on food that you ate more than a day ago. People think of the last things they ate as the things that have caused their foodborne illness, and that can be, in fact, is often the case, but it is not always the case, and that's why, as on traceback calls, we need to make sure that we're asking not just about the previous day, but several days prior to the development of symptoms. So that's expanding your question a bit, but the bottom line is that we believe that these routine inspections do, for a number of reasons, prevent foodborne outbreaks, including the direct findings, but also the knowledge that the food inspector is coming back causes them to, and they don't know when the food inspector is coming back, causes them to maintain hygienic practices all of the time. But we do count on people making complaints to us so that we can make specific investigations as indicated. And again, some of the inspections you go on will be complaint investigations, and others will be routine inspections. You'll hear later from Michelle as she talks a little bit about the observational form and some of the experiences they have in piloting the form about different kind of event. I'll just preview it briefly. There was power loss the night before they went out on inspections, which meant that temperature drops had the potential to create foodborne illnesses through improper temperatures. So that's a very fortuitous event for our graduate observers. And Michelle will talk about that in more detail later. Any other questions before we move next?
If I understood correctly, Michelle said when the Corky and Lenny case, when the first cases were reported, other Ohio departments of health were notified?
Yes.
Why were they statewide, all of them?
Sure, because people travel.
Okay. So is there a standard of level of when they're all notified, or just like one person gets sick, or two, or five, or any illness?
That's a good question. I can't really answer that question because the criteria is as little as 2 people from the same food source. Clearly, the whole state isn't notified all of the time. What I will say is that in Cuyahoga County, we are notified all of the time, even if it's just 2 people. we have a system for Cuyahoga County referred to as a drop system, many other counties or regions have the same thing. DROP stands for disease reporting, something protocol, blanking on the O in the DROP protocol. But what it means is that every time there is a report of an infectious gastroenteritis or flu, any infectious disease, in our jurisdiction, my jurisdiction, we would notify through this drop system Cuyahoga County and Cleveland. If it happens in a Cuyahoga County municipality, they would inform us in Cleveland the same thing. So there is no infection that goes on in Cuyahoga County that all three jurisdictions aren't aware of. When appropriate, that's shared with our surrounding counties as well. My take would be that I don't believe that there is a threshold at which critical mass is reached always or automatically disseminated more broadly, but it would start at the most local level, and the larger the number of cases and the level of concern, the more likely it would be to spread across county lines and perhaps even across state lines, depending on the magnitude of the problem.
I'd be a lot of people if this is no one or two people,
Right. That's the tightrope that we walk is not doing make work, making other people do work when they don't need to, but making sure we get information out that allows us to gather the fullest information. And I'll be going through some statistics a little bit later in this portion of the talk about foodborne illness in Ohio and how much we see of that in Ohio. So that may give you a little bit better sense of what to expect. So I'll be talking about investigation and management and what we think of as the case study component of this project. This project is being started in phases. We're starting with the prevention phase. And I think that we've got pretty good timing in doing that. As you saw with the seasonal variation, the months of March and April are relatively low in foodborne outbreaks, and they go up. May, but especially June, July, August are the highest rates every year of foodborne outbreaks. So our hope is to get people in doing the preventive observations first, and May 1st is our goal for implementing the second stage of this process. Any of you who continue to be involved with this project will be part of that phase as well. It won't be more work for you, but what will occur is that if a foodborne outbreak occurs in your jurisdiction, it's all hands on deck. You drop the preventive observations and instead place your attention on the case that's occurring in your jurisdiction, whether it started in your jurisdiction or whether you have people in your jurisdiction who got the illness while in another jurisdiction. We were talking a little bit on the break. It's not that there aren't any Shaker residents who had foodborne illnesses. It's that none of those foodborne illnesses have been traced back to a Shaker source. They got their foodborne illnesses in sources that we were able to trace back outside of our own community. So we definitely are involved in investigation of infectious diseases in Shaker, but would not at this point from a Shaker restaurant. So the case study component will follow the CIFOR-based review template, and that is that there will be, we will look specifically at what the investigative procedures are, what the reporting procedures are, laboratory support documentation, how the health departments do the traceback calls, any recalls of products that are out there that may be contaminated, how the media is managed, and how they both review their response to the foodborne outbreak and make plans for improving their process as a result of that review. So this whole process will be different across different communities because there will be different actors involved depending on how the health department is both staffed and organized. Some, as I mentioned, would be having epidemiologists doing traceback calls, some nurses, some physicians, some sanitarians, depending on the organization of that health district. CIFOR objectives are short-term, intermediate, and long-term, and we will be looking at all of these. So the short-term objectives, when a foodborne outbreak is present, is to detect that foodborne disease that are of public health importance, and actually probably the real answer to the question about when we would report back. We'd be in consultation with ODH, the Ohio Department of Health, in making that decision about whether to disseminate that information statewide or not. And we probably decide as a Cuyahoga County Public Health Collaborative, the group of 3 health departments, whether we were going to seek that advice from ODH based on our experience. So that's sort of the process that would go on if we were doing it here in Cuyahoga County. So again, short-term objectives: respond to events in a timely manner and intervene when appropriate to prevent illness. Intermediate objectives include determining the etiology, vehicle, and contributing factors of the foodborne outbreak, monitor trends to identify emerging foodborne problems, increase knowledge of foodborne disease causes and abatement strategies, and that would include both with the food service establishments and with the general public. Long-term objectives would be to prevent future outbreaks, reduce incidence of foodborne illness, and increase the health of the general population. I hope one of the things that you're getting a sense of is that if we find things that appear to be working particularly well in some of the districts that we work with, a next step would be to try to disseminate those practices to other communities. If there are districts that don't have a drop system, we might be seeking to encourage them to implement such an approach. We wouldn't be doing that during this study. That would be a recommendation that would be a result of this study. We will change our protocol, but we won't encourage districts to make specific changes until we have a full set of information to work with. We'll be talking a little bit about what to do if we believe that there's a problem that could be prevented based on the observations that we make. How do we handle that ethically and practically? And we'll get to that later in our conversation today. So you can see, for the CIFOR objectives, we've got an opportunity to gather information at every phase and make recommendations, perhaps based on these observations, about how to proceed in the future. So investigation, excuse me. When there is a foodborne outbreak, observers will be involved. In 2009, there were 56 outbreaks identified in Ohio. 21 were confirmed as foodborne outbreaks. The bottom line is that we will have in the range of 30 or so health departments that we're looking at out of the 125 in the state, but we also will have some of the larger health departments in the state that we're involved with. So the extent to which we have foodborne outbreaks occurring in our health departments, we're virtually guaranteed to have some, but we're also virtually guaranteed not to be overwhelmed with them. In the past 5 years, I think the largest number that I recall was 78, something like that, in the high 70s of foodborne outbreaks that were identified. That, of course, that doesn't mean that's how many there were, that's how many were identified. As you can see, not all outbreaks that are identified are confirmed as foodborne outbreaks, which is to say the source is never really found that would confirm that in fact an outbreak occurred, or the lab samples aren't conclusive that the same infectious agent was involved for each of the cases in that system. The approach that we will be taking is referred to as a comparative case study approach. That actually goes for the preventive observations as well, and is a well-accepted approach to PBRN research, and it will provide an opportunity to observe the investigative process when possible after a foodborne illness is reported. Now, this process of the case study of investigation and management will be quite different than that of prevention, because prevention happens routinely and predictably, and you should not be slowing down the process of preventive evaluation through your observations. In fact, the complaint that we hear consistently from local health departments is that they're really tired of doing self-report surveys. So this is a way to gather information without asking them to do a survey on their own. We will be doing brief interviews before and after, but there's downtime before and after. It's not as if it's going to take them longer. There's always travel time to and from these inspections. So you're in fact going to be helping them by gathering information about something they care about in a way that doesn't interfere with the way they do their job. The other thing that's really important to emphasize is that as you fill out these forms, that you're not judging the performance of these sanitarians. You should not be offering critiques or criticisms. If they ask, how did I do? I would simply reflect that to them and say, I'm just a student. How do you think you did? We are not in a position, even as you become more experienced, you should not view yourself as sitting in judgment of or as the evaluator of the sanitarians that you're observing. Any hint of that, and you will have a much more difficult time relating to that sanitarian in the future. But the investigative side of it won't slow down for you. They won't wait for you to make it to a meeting. They won't wait for your involvement. It will depend on the jurisdiction and the nature of the jurisdiction. Our hope is, for example, in Cuyahoga County, that we can get the student observers added to the drop list so that they know, as we know, when these things are happening. And we'll look to do that in other jurisdictions as well. Much of the communication that happens around these incidents is by email. You don't need to watch someone type in order to have an observation of the process of communication if it's primarily an email process. Almost all of the traceback investigation is done by telephone. So most of the time the person investigating isn't going to the person's house and talking with them about it unless the house is a possible source of the infection. There will be site visits to the possible source of infection, but that can get included as part of the complaint observations of the sanitarian role. There may be specific complaint operations where through our communications with the health departments we're working with, they can call us and say, we have a complaint that we think is serious. Do you have somebody who can come out and watch this observation. And if we do, then we'll do it. If we don't, we won't. The advantage we have is that even if we don't observe it, we will have access to the report they generate from that complaint investigation. So this will be a less consistent portion of the study, the investigative part. We will seek multiple different approaches. We will try to encourage, we have to get it IRB approved first, but encourage you to be included as on a conference call to traceback calls if the person being called is agreeable to your involvement. So all of these represent opportunities to learn more about how these things happen and observe them to the extent possible without breaking the chain of investigation or slowing the investigation down in any way. The investigation, we will seek access to discussions that follow the complaint or report to track the protocol utilized to conduct the investigation. We'll look at those CIFOR guidelines that we've discussed in detail to see which portions of those CIFOR guidelines are being approached. And I will say, because Purva mentioned CIFOR training, that Cuyahoga County last fall, I believe it was, held a CIFOR workshop for all regional health departments, not just Cuyahoga County, but all health departments in the region, and it was very well attended and very well conducted workshop. So again, even though we have less public health funding, we do a really good job at getting this disseminated. Only 27%. We're planning on disseminating and using CIFOR guidelines. Well, we're part of that 27% in the Northeast Ohio region as a result of that workshop. So if an outbreak is declared, we'll seek to observe development and administration of the investigative tools. There is a standard traceback form that health departments use, but it may be different from health department to health department. Again, a recommendation may be to standardize the traceback form used by all Ohio health departments. But I suspect when we first start, we'll find that different health departments use different forms. So we'll look for any opportunity for involvement that is practical to both the health department and the students. These situations, each of these situations, in the prevention situation, you'll be learning a lot about what's happening there. In the investigations situations, it's a little different set of knowledge that you'd be gaining, but an equally good and frankly somewhat more exciting portion of the study. Will be looking at what happens when these outbreaks occur. Then in addition to the investigation, a really key part of what we do is management. Sorry, one more observation slide. So observations of field inspections and office-based gathering, I already mentioned these. Certainly if there are meetings that are being held between jurisdictions to talk about outbreaks, trying to get a student to attend that or to call in and listen via conference call would be yet another way we could become involved. And it, as I said, all depends on observers' time and availability and the speed and path of the investigation that occurs. Management of the investigation also happens in real time and won't slow down for us, but management is primarily the task of the local health department leaders, and when I say that, the key leaders here would be the director of the health department and the director of environmental sciences or environmental health within the health department, those would be the two key actors, and they will involve sanitarians, epidemiologists, those who are on the front lines of gathering the information, but the decisions will be made by the local health department leaders. And again, Cuyahoga County, that generally involves all three health directors making decisions and offering input to each other on how that works. Again, across jurisdictions, across county lines, we'd be seeking these multiple sources of input so that because these diseases, foodborne outbreaks, don't respect jurisdictional boundaries, we need to be as inclusive as possible in decision-making about how we proceed. We will also observe how victims, potential victims, and public are informed regarding safety and protection measures. You see that happening on a routine basis on the news. Alfalfa sprouts and peanut butter cases that Corbett talked about, but more recent listeria infection with cantaloupe. Those weren't restaurant-based foodborne infections, but are examples of the kind of risk communication that occurs when foodborne outbreaks are present. Oops, sorry, wrong direction. The involvement in management may also be based on email or conference call presence, and we will be observing the steps taken to improve outbreak response for the next incidents. Those are generally planned meetings and would be easier for a student observer to attend for those planned meetings. Mentioned before that the complaint may start from a consumer. We actually will be moving toward a consumer component to this process as well. We've received a DOLPH supplemental grant already that will allow us to investigate consumer response to the foodborne investigation, outbreak investigation. That includes the food service establishment as a consumer of public health services. We will be conducting interviews of food service establishment personnel to get their perception of the process of preventive and investigative procedures that occur. We'll be talking with those who have developed the illness about illness perceptions and beliefs and perceptions of the general public about local health department investigative process and interaction. This is an added-on component of the study. Whether you're involved with this component of the study would really depend on your interests. But one of the things that I would strongly encourage you to do is be thinking about niche projects that you may be interested in. You all will have some sort of either capstone or culminating project that will be required of you as you complete your program. If you're interested in looking at a niche within this, and you can see from that black box that we illuminated just how many niches there could be, and this makes further niches here as we go out of the black box into the general public, be thinking of something that may be of interest to you. Michelle has a head start, so she actually has already thought of a niche that's of interest to her, and that is investigating the study itself. How well do our tools and instruments work in terms of whether we're seeing consistent ratings across different observers of the same phenomenon or not. If we're not, if there are particularly items that are not getting good agreement between different observers, then we may simply eliminate those items from the survey because we'd be reporting on topics in which the variation was too great to justify continuing to include that in the study. So this does involve studying the study, and that is also part of the supplement that we've received. So that will involve looking at the validity, reliability, and generalizability of our study. But just as important, looking at the utility. In other words, is the information we gather useful? Will it offer information that will contribute to policy or practice change? Will it help decrease error variation? If it doesn't, then it doesn't have high utility. And then looking at the acceptability. How do the student observers perceive their role? How do the sanitarians feel about being shadowed? How do public health leaders feel about keeping students in the loop? Each of these things would contribute to the acceptability of the methodology. And finally, does the approach deliver as promised at giving a better way of understanding both complexity in public health and error variation? If it doesn't have those advantages, then it may not be worth continuing to apply this methodology in a public health setting. All right, that's what I wanted to say. We're at a point for questions and moving to lunch, and we're actually a little bit ahead of schedule and moving in those directions.